whereas the relationship between the drug concentration and the effect which is producing will be explained by the pharmacodynamics. How it is going to be acting upon, guys? As you can see in this flow chart here, the drug is going to bind with the target proteins, and by binding with the target proteins, it is going to be producing either a therapeutic effect or it might produce an adverse effect. But what are the target proteins which we have? Majority of the targets which we have currently in treatment of pharmacology are proteins, guys. Only minority, only 1 or 2% of the drugs are concentrating on carbohydrates and fat molecules. Even those carbohydrates and fat molecules, or those drugs which might decrease the lipid levels, or those drugs which might decrease the sugar levels, also will be acting upon by certain proteins. How it is going to be having the link between the protein and the other forms? This is with the help of 3 major types of the target proteins, guys. It might be either a receptor, or it might be an enzyme, or it might be a transporter. Receptor, enzyme and a transporter. We will be talking more about this receptor and enzyme in the oncoming sessions. But what about this transporter, guys? Transporters are simple. There is no separate pharmacology to be dealt with. It just follows the same phenomena which we are going to explain up as per receptors is concerned. For example, I am just giving a few examples of drugs which might be targeting transporters in the human body. Example, we have the serotonin transporter. We have a transporter called a serotonin transporter, which is targeted by the tricyclic antidepressants or selective serotonin reuptake inhibitors. These drugs are your antidepressant drugs. These drugs tend to inhibit the serotonin transporter. It is a transporter that is getting inhibited. We have VMAT, vesicular monoamine transporter type 2, that is inhibited by reserpine. Then we have GABA-T, GABA transporter, which is inhibited by tiagabine. Then we have organic acid transporter, which is inhibited by probenecid, and we have sodium potassium 2-chloride co-transporter, which is inhibited by the famous diuretic agent, the life-saving drug, that is furosemide. So these are the different drugs which might be targeting the transporters in the human body. What about the receptors and enzymes? Let's talk in detail about the receptors first. Let's talk about receptor pharmacology. What exactly is receptors, guys? See, receptors are these things which is there on the surface of a particular cell, or it might be there inside the cell. Thereby, it is going to be producing certain responses. It has got 3 major functions. The first function is this receptor is responsible for the quantitative relationship between dose and the pharmacological effects. The relationship between dose and effects, that is going to be demonstrated, that is going to be practicable only with the help of these kind of receptors. The second one, a drug is going to be, if it is administered, it is going to act only on a particular area, right? If you give paracetamol, it is going to be decreasing only the temperature, or it is going to be useful in pain. It is not going to be treating the infections, right? It is not an antibiotic, right? So how this difference tend to happen? With the help of receptors. The selectivity of drug action is based on the receptors. And the last one, this is also an important one which is responsible for production of antagonists. So we have certain antagonists. We can block certain activity. We can also induce certain activity by binding or by altering the actions of the receptors, guys. So how this pharmacodynamics is going to be dealt with? We are going to deal with the relationship between what and what, guys? Plasma concentration and the effect which is produced, right? Previously in pharmacokinetics, we would have seen about the plasma concentration versus time plot. We have seen about certain other plots which is concentrating the dose and the plasma concentration also. But here, as we are dealing with pharmacodynamics, we are dealing with concentration effect curves. What exactly is this concentration effect curve, guys? Before seeing what exactly the curve is, you have to have some basic knowledge. Consider I give 10 milligram of a drug, and for this example, it is going to be producing 10% of a response, or consider it is a smooth muscle. If you give 10 milligram of a drug, or the plasma concentration is 10 milligram, it tend to produce 10% of the smooth muscle contraction. If you give 20 milligram, it is going to produce 20% of the smooth muscle contraction. 30 milligram, 30% of the smooth muscle contraction. But 40 milligram, it is not going to produce 40% of smooth muscle contraction. It just produces around 35 or 36% of the smooth muscle contraction. When you give 50, it is going to produce just 42% contraction. When you give 60, just 45% contraction, which means as the dose or the plasma concentration increases, the effect will be increased. It's a phenomenal one, it's a proportional one. That's what the mathematics says. That's what your body also will say. But the increments, the effect increments is going to be lesser as the dose or the plasma concentration increases. Which means previously for 10 milligram increase, there was 10% increase in the effect, right? Now for 10 milligram increase, there is just only around 5% rise in the activity. And at the last one, if you give 10 milligram, only 2% rise will be there. This is what we used to call them as the effect increments is going to be decreased.